Hello, everyone. Welcome. My name is Barragan-Carrillo. I'm at City of Hope Comprehensive Cancer Center in Southern California, and right now I'm sitting here with Dr. David Braun from Yale Cancer Center. So, Dr. Braun, first of all, fortunately, now we have the option for Pembrolizumab, which has shown some benefit in overall survival in patients who receive it in the adjuvant setting. Who are the patients that you are offering this option to once they get their nephrectomy?
It's a good question. I tend to follow the Keynote 564 criteria. So those patients with intermediate high-risk disease, so T2 if they have high-grade, grade 4 sarcomatoid, any T3, a T4 N1, and then finally M1 NED if they've had their metastatic site addressed within 1 year of nephrectomy. So I tend to follow that in terms of my discussions, but everything gets individualized. So someone who has a low-risk T3 with low-grade disease, no vascular invasion, that's definitely much more of a risk-benefit conversation than someone with much higher risk disease.
Great. And for these patients that receive the 1 year Pembrolizumab and later present with a recurrence, how do you advise them? How do you approach them? Because there's not much very high-quality data in this setting.
That's absolutely right. And that's one of the first things I acknowledge. I'm always upfront and I say, look, there's not a lot of data to guide us in this space. And so I don't think there's a perfect answer. I think some people have looked at timing as one answer. It's just try to say, when did you recur relative to finishing Pembrolizumab, or was it during Pembrolizumab? In the absence of data, I don't want to deprive someone of potentially a long-term response that I think people can sometimes obtain with regimens like Nivo-Ipi. And so I tend to offer that standard upfront therapy, knowing that the response rate is probably going to be substantially lower, but that there is still a chance of long-term responses. We know that IPI can be effective, small numbers of patients, but can be effective after anti-PD-1. And so I sort of extrapolate from that and use that regimen a fair amount post-adjuvant Pembro.
Thank you very much. That's very interesting. And in full honesty, since I can remember, there has been this debate about IO-IO against IO-TKI.
Absolutely.
Which factors do you actually take into account to decide one regimen against the other, or do more of the approach to select one and stick to it until you feel comfortable offering it?
So among the IO-TKIs, I think there's more similarities than there are differences. There's tweaks, but there's more similarities. I think there is a difference between the pure IO-IO regimen. I think the upfront responses are certainly lower. I think that is almost certainly true. But I also believe that if a response is obtained, the chance of it being durable is substantially higher with an IO-IO regimen. And so that's really how I think about treatment. If I need an urgent upfront response, I'm going to lean towards an IO-TKI because I don't have the luxury of thinking 3 years from now. I'm thinking 3 weeks or 3 months from now. But if someone has the luxury of being able to try for that long-term durable response, which is the majority of my patients, I tend to favor that IO-IO approach.
Great. And is there any setting where you would use data, for example, from an NGS, either in the tumor or from the blood, to guide your decision?
It's a good question. I wish we were at that point in kidney cancer where we really had sort of mutation-directed therapy. I just don't think that we're there. I sometimes use it more in a diagnostic sense if I really have trouble distinguishing between different histologies. But therapeutically, I don't think it really has a role in kidney cancer right now.
Thank you very much. And just to close up, how do you approach these patients with non-clear cell histologies in the metastatic setting?
This is an ongoing challenge. And I think the real answer is this is exactly where we need more studies. We need to really understand the individual biologies. Papillary is different from chromophobe, is different from translocation. Obviously, those are radically different from things like renomedullary carcinoma or collecting duct. So, I tend to individualize it. I do use similar regimens. I do use Nivo-Ipi. I do use things like Pembrolizumab based on the B61 data. But that's really a space where we need more clinical trials.